Myopic macular holes actually it's a topic on its own غير idiopathic macular holes عشان ال complexity of the pathology بتاعت this type of holes فهو ليه entity لوحده عشان كده واخد discussion as a separate entity. Myopic macular holes are these holes that occur in patients with pathological myopia 26.5 millimeters in axial length or -6 diopters in refraction. Treatment of myopic macular holes is a surgical challenge even with experienced surgeons because of the complexity of the pathology and the complexity of the anatomy of highly myopic eyes. So the pathogenesis of myopic macular holes is very peculiar وايه اللي بيخليهم different عن idiopathic macular holes ان هم tractional forces are really complex. Very strong anteroposterior, very strong tractional forces. Additionally, we have the centripetal force from the posterior staphyloma. So we have the very strong anteroposterior traction by the vitreomacular traction, and we all know that in highly myopic eyes there is a very strong vitreomacular adhesion, and these patients usually have some sort of posterior cortical splitting of the posterior vitreous, which is called vitreoschisis. So we have a very strong anteroposterior traction. Tangential traction is very strong in highly myopic eyes because they have very stiff ILM, they have very stiff epiretinal membranes, and this adds to the tangential traction. Additionally, this is very peculiar about the myopic eyes, the posterior staphyloma itself, which causes the splitting of the macular area, causing the foveoschisis. Actually, the outer retinal layers may conform with the posterior staphyloma as the staphyloma enlarges with time, but the inner retinal layers are very stiff because of the blood vessels, because of the epiretinal membranes, and because of the ILM. So this makes the retina split and doesn't conform with the posterior staphyloma, causing the macular splitting or the foveoschisis, and this is the major challenge for the closure of these types of holes. By microscopic identification of these types of holes is difficult because of the poor contrast. يعني على slit lamp we can difficultly detect them sometimes because of the poor contrast between the defect in the neurosensory retina and the underlying RPE. Sometimes these patients have chorioretinal atrophy in the macular area, and already they have a deep posterior staphyloma, which makes the examination more difficult. So after the introduction of the OCT, it became the standard for the diagnosis of these patients. The OCT is able to give us a lot of information about these myopic macular holes, which helps in how can we tackle these patients. It gives us an impression about the defect, where it is according to the retinal layers, because myopic macular holes can be also full thickness and could be partial thickness or lamellar holes. So it tells us if this hole is a full thickness one or is a partial thickness one, if there's still epiretinal membrane or tangential traction, do we have foveoschisis or not? Do we have neurosensory retinal detachment associated with the hole or not? And it brings us information about the premacular or the vitreomacular interface. So according to the OCT, we can generally divide the myopic macular holes into two types, or actually not two types, into different entities. We can divide them into full thickness holes and partial thickness or lamellar myopic macular holes. Each of them could be associated with foveoschisis, with or without foveoschisis, and each of them could be associated with neurosensory detachment or not, with or without neurosensory detachment. So it could be a myopic macular hole with or without foveoschisis, with or without neurosensory detachment. What about the lamellar holes, the lamellar myopic holes? Further classification of the lamellar myopic holes have introduced another division, dividing these types of holes like we see in the third picture from above, the inner lamellar myopic macular holes. And these inner lamellar ones are somehow benign ones because they are caused by tangential traction, and if we go into the surgery and peel the ILM, they may completely respond to peeling the ILM. The main problem comes from the outer lamellar myopic holes, which is the fourth picture from above. These holes are caused by the complexity of the anteroposterior traction and the posterior staphyloma. And if we go with a vitrectomy and peel the internal limiting membrane in these cases, these patients will immediately develop a full thickness myopic macular hole. So these patients should be treated with the inverted flaps as mentioned by Dr. Ahmed Abdelbey. So myopic macular holes could be full thickness, partial thickness, and each of them with or without foveoschisis. If we can see a lamellar hole, we have to know if it's an inner lamellar or an outer lamellar myopic hole. So the management of myopic macular holes is always a surgical challenge, and because of that, many surgical procedures have been introduced in order to improve the anatomical outcome. And currently, it's widely accepted that the vitrectomy with the inverted ILM flaps provides the best surgical outcome or the success rates. And according to that, further modifications have been made on the inverted flaps. So the inverted flap technique itself has passed through a lot of modifications. We have the inverted single layer flap, which could be temporal or superior. We have the inverted multi-layer flap, which is the envelope technique, with or without plugging the ILM inside the hole. And we have the free ILM graft. And recently there has been the autologous retinal transplant for resistant or recurrent cases and can be used in myopic holes as well. And all of these techniques could be associated with the use of autologous blood to close these holes. So according to the literature, several studies have been conducted to study the rate of closure in myopic macular holes that are not associated with with retinal detachment, and it was found that there's a high success rate if we do ILM peeling with an inverted flap technique in these patients, reaching up to 100%. It ranged from 94 to 100%. These are myopic macular holes without retinal detachment. What about the myopic macular holes with retinal detachment? Similar studies have been conducted, and in the meta-analysis, it has been shown that 50 to 70% closure rates could be achieved in patients with myopic macular hole detachments, myopic macular hole associated with retinal detachment. It was debated as if could these inverted flaps interfere with the healing of the myopic macular holes or not, and there was a study in 2019 that showed that the inverted flaps did not interfere with the natural closure or the natural anatomy of the macular area after closure. And even, I think this is a single study and many studies should be conducted in that manner, but I think, yes, they also concluded that the ILM plug that they did see in some cases did not interfere with the restoration of the outer macular layers like the external limiting membrane or the ellipsoid zone. Recently, it has been widely adopted that we fold the ILM under perfluorocarbon, and I actually do this technique. So what is the benefit that perfluorocarbon brings us? Why do we like to fold ILM under perfluorocarbon? Because actually the perfluorocarbon adds to the polarity of the ILM flaps. It brings them more polar, and these highly polarized flaps adhere and stick to each other strongly, and they do not open easily further post-operative. Additionally, these highly polar flaps are highly elastic, so when you peel the ILM, even if it's very thin in myopic eyes, it doesn't shred into smaller pieces. It becomes very elastic, and you can easily manipulate the ILM and put it in the inverted flaps as you'd like. So if we have time, I have a lot of videos. If you have time, we can go through the videos? Okay, so I'll conclude. So actually, the inverted flap technique is the treatment of choice or the approach of choice for highly myopic patients. It brings us a high success rate, reach up to 100% in patients without detachment and 70% in patients with retinal detachment. Folding the ILM under PFCL could bring us better results by controlled flaps.
If you have video for 1 minute or
I have
so,
I have few videos.
Yes, you can use it.
Maybe I'll show one case. This is a case was a full thickness myopic macular hole with an epiretinal membrane and foveoschisis, and this was a one-eyed patient with a posterior pole localized neurosensory detachment. And in myopic holes, I like to stain under air to bring a better contrast. At the beginning, I used to create the first flap without before injecting the perfluorocarbon. So in this case, I created the first flap and then injected the perfluorocarbon, and then I'm peeling the ILM here under perfluorocarbon to bring. This is a very this was one of my very first cases. So we can see that the ILM is very thin, but actually it doesn't shred. You can see it's very elastic, very controllable under perfluorocarbon. It doesn't break into smaller pieces. So this is the actual benefit that brings us from peeling the ILM under PFCL, especially in highly myopic eyes. We can do this if we want to create inverted flaps. Maybe we can do it, not use perfluorocarbon if we're not in high myopic eye, but especially in myopic eyes with the ILM very thin like that, we have to do it under perfluorocarbon. Maybe I can go through another case. There's time. Thank you.